Hello everyone, good evening once again. I'm Dr. Rucha. Welcome you all on behalf of Team Metrics. We have one really good topic discussion today, a new era in diabetes treatment. So precision medicine will be discussing with Dr. Om Lakhani. Sir is consultant endocrinologist based in Ahmedabad. Hello sir, and it's always pleasure to have you to discuss different topics, and it's always been pleasure to play quiz as well with you. So welcome again for today.
Thank you. So, good evening, everyone. And I can see about more than 120 people have joined today. So, thank you for sparing this time to learn something which is very different, something you would not have come across probably in the recent times. But this is something which is changing the diabetes landscape very quickly. In fact, if the 2022 ADA meeting that I attended, I think the major focus was actually precision medicine. This is something which is the cutting edge of diabetes management, and this is something which is going to change the diabetes management as we know it from bottoms up. Uh, before we really change, right? So I am Dr. Om Lakhani. I am a consultant endocrinologist, and I also think of myself as a technocrinologist. So this is a word, well, it's a self-made word. So, and I'm going to talk to you about precision medicine and diabetes. So this is the outline of today's presentation. So we'll talk about what is precision medicine and why do we need precision medicine in diabetes in the first place. What is the present status of precision medicine development? What is the world going to? Where do the various guidelines support this? Organizations, do they support it? Now we are making a precision medicine platform called Diabetology.co.in. I'll give you a glimpse of that. What it is, and we recently, I'd like to announce that we recently been funded by RSSDI. So we got a small seed fund for research for this as well. So this is something which is very I think a big thing for us. And finally, some take-home messages. So not only am I going to tell you what precision medicine is, but I'm going to show you what precision medicine can do. So that is the today's exciting talk. Okay, so what is precision medicine and what is personalized? So precision medicine, we all have heard this term tailor-made approach, right? We, when you go to buy a nice suit or a nice blazer, you could do one of two things, right? Either you can go directly to a ready-made retail shop and buy your suit, which should be very nice. It may look very nice on you, but it's not made for you. Or perhaps you could go to a tailor who will take your sizes and who will take your measurements, and based on the measurement, he would, and based on your skin texture, based on your complexion, based on other things, he'll select the color, he'll select the texture, he'll select the, the size of your suit, and he'll make a perfect tailor-made suit. So that's the broad difference between the regular retail medicine that we practice and precision medicine. And as patients are becoming more and more aware, and as the type 2 diabetes, we are understanding the disease better, we are now moving away from one size fits all approach where every patient who comes to us, we give them metformin, glimepiride, this, that, depending on who, what medicine is available to us. Rather, the idea is that you see the patient, you analyze the patient, and based on the analytic data that you get, you give the perfect treatment for that patient. That is what precision medicine is. So precision medicine is what takes the patient's clinical, laboratory, genomic data into account and provides a precise medicine for that patient. Then there is a term called personalized medicine, which is one step ahead of precision medicine, which is basically it takes the precision medicine plus it also takes the patient's factors into account. The patient's cultural beliefs, economic constraints of the patient, all the other things into account. When I was a resident in medicine, I remember I worked at a government medical college, and I remember that personalized medicine is what we had to practice because if I prescribe a particular drug or a particular insulin to a patient, if the patient cannot afford it, the patient is not going to take it. So hence, it's very important that we personalize the treatment based on the patient's preferences rather than just based on the clinical data, which is there. Okay. So let me take you to a case. So think of this as a prototype for precision medicine. And whatever discussion we're going to carry forward is probably based on this particular case. Now, this is not a real case, a fictitious case, but you might encounter this case, such a case in clinical practice. So we have a 25-year-old male patient, right? And the patient is, having BMI of 32. which all of us would agree that the patient is obese. Patient, however, has history of polyuria, polydipsia, and weight loss. So he has significant weight loss, polyuria. On evaluation, he has a random sugar of 380, and his HbA1c is 12 grams per centimeter, right? So, he's in glucotoxic stage. Interestingly, he also has urine ketones positive. However, he has a strong family history of diabetes, and we did a GAD antibody, which was negative, right? So this is the context of now. What is this? What does this patient have? You would ask me, does this patient have type 1 diabetes? Does he have type 2 diabetes? Does he have MODY? Does he have LADA? Right now, for those who are very interested in these terminologies and how diabetes is different and also unified, I wanted to go back to another talk we had on this platform, Netflix, where we talked about unified theory for pathogenesis of diabetes. I think this is something which you should really be looking at, to try and understand my thinking, my philosophy better in terms of diabetes. So if you see this patient as a whole, this patient there could be arguments in both sides. Is this patient type 1 diabetes? Now, what are the arguments in favor of type 1 diabetes? So patient has history, is a young patient. He has polyuria, polydipsia, weight loss. So he has symptomatic hyperglycemia. He has what is known as osmotic symptoms. He has urine ketones which are positive. So all these things favor possibility of a type 1 diabetes. What are the factors which favor possibility of type 2 diabetes? Now you have the patient being obese, right? So that is one aspect. You have the patient's strong family history of diabetes. And remember, contrary to popular belief, type 2 diabetes is the one which has stronger family history compared to type 1. So again, type 2 diabetes, the strong family history favors, type 2 diabetes. Patient has GAD antibody, which is negative, again favoring type 2 diabetes. Could this patient have MODY? Less likely, but yes, patient has a strong family history. So, that these are things so it could be anything. It could be, various pathogenesis. So that's why it's very important that we give the right treatment. So when the patient comes to us, we need to provide the right treatment. Remember, we also don't have lot of time to sit with the patient and probably analyze the patient for an hour before we give the treatment. We almost have to give treatment instantaneously. You have to take the decision on the spot and treat this patient. The patient will probably not wait for you to, think about it, deliberate, right? So what are the questions in terms of precision medicine for this patient? First, precision diagnostic. What type of diabetes does this patient have? Right. So that's the first aspect, which is precision diagnostic. Right. Does he have type 1? Does he have type 2? Does he have LADA? Then you have precision therapeutics. So once you make the diagnosis, let's say it comes out that the patient has type 2 diabetes. Then what kind of medications would you give? Would you give insulin to this patient? Would you like to give this patient sulfonylurea? Would you like to give this patient SGLT2? Would you like to give this patient metformin? What treatment would you give? So that's precision therapeutics. And then precision prevention. That is, what kind of complications does this patient potentially have? And how can you prevent those complications from developing? So these are the questions which a precision medicine algorithm should try and answer. And remember, all these things has to be done within seconds, within minutes. Why? Because your patient is not going to sit for long in front of you, trying for you to think and analyze and assess. So what is something which can do instant, give you answers instantly? Obviously, it is a computer, right? And an algorithm, perhaps even AI. So that's the whole context of where we are going when we're developing precision medicine. So let's talk about the diagnostic part of it. Does this patient, what type of diabetes this patient has? Like we already discussed, is this type 1? Now it could be, right? So type 1, this patient has GAD antibody negative. So which other antibody is positive? So which antibody? And remember, whether this antibody has a different impact on the patient's progression of the disease, probably not. What is the rapidity of the progression? So we know that LADA is a slowly progressing type 1 diabetes, whereas some cases of type 1, and we'll discuss this later, subtypes of type 1 also, some forms of type 1 rapidly progress. What if this patient has type 2 diabetes? Which cluster of this type 2? So type 2 diabetes has multiple clusters. So which cluster does it fit into? Is he having severe insulin deficient diabetes? Is he having combined insulin deficient and insulin resistant type of diabetes? Does this patient need insulin? Does this patient require oral antidiabetics? Which OAD would you give? Is this MODY? If it is MODY, what type of MODY it is? Does he need treatment at all? Because some bodies don't need treatment. And if a treatment is needed, what would be the right drug for this patient? Right? I'll tell you an interesting story. We, in fact, saw one patient, we diagnosed a patient with recently. So I'll tell you that. And then you look at other causes. So does this patient have Cushing syndrome? Maybe it could be a secondary cause of diabetes. Does he have drug-induced diabetes? Maybe the patient was given glucocorticoids. Maybe patient has acromegaly. Right? So these are all questions which a precision diagnosis would be able to answer. So I promised you a subtype of type 1. And remember, type 1 also has subtypes. So there are 3 identified subtypes of type 1 diabetes. You have acute onset of type 1. That's the most typical form of type 1 that you see in your children. This is typically seen in the pediatric age group between the ages of 5 to 15 years. That's the typical age group where you see this type of acute onset type 1. Then you have the LADA, which is latent autoimmune diabetes of adulthood, which is which the new terminology for it is slowly progressive type 1 diabetes. So this is basically a slowly progressive form of diabetes where the clinical manifestations and autoimmune destruction typically occurs much later. So patient has preserved beta cell function. So typically this patient tends to initially respond to oral drugs as well, and then eventually requires insulin. And then you have some other form of type 1 diabetes, which is a fulminant type 1 diabetes, where you have a rapid and instantaneous destruction. We have seen this type of cases in during COVID, where you have rapid destruction of the beta cell. The antibody comes, destroys the beta cell, and goes away. And when you see this patient, the patient is completely having complete beta cell dysfunction, and the antibodies are also completely negative. So that that type of diabetes presentation is what is known as the fulminant type 1 diabetes. So you can see from here, you can see the fasting and postprandial sugar values, how it progresses, and also the insulin levels, right, in these patients. So in the picture on the right. Okay. Then of course there were a lot of attempts, and there are ongoing attempts to subtype type 2 diabetes. Now, I'm sure all of you would have seen different forms of type 2 diabetes in your practice. Some which some are thin, some are fat, some are obese, some are some respond to insulin, some do not respond to insulin. They are extremely insulin resistant. Some develop diabetic ketoacidosis also, so there is ketosis prone type 2 diabetes. Some of them develop diabetic nephropathy, some of them develop cardiovascular disease. So each of these type 2 diabetes are different. Every type 2 diabetes is different patient. Obviously, we cannot individualize everything. Of course, we should, as precision medicine, we are trying to do. But at the same time, is there a pattern in different types of type 2 diabetes? And that is where, a lot of people have tried to ask this question and try to find answers. The first group which tried to do this was the Elquist et al. From Sweden, where what they did was that, so if you take the Scandinavian countries, they tend to have a very good database of their patients. They keep a very meticulous record of the patient. So they did analysis of the patient data of newly diagnosed patients with type 2 diabetes or with diabetes per se, and they classified these adult patients with diabetes into 5 different clusters. Found that there are 5 different clusters of type 2 diabetes. So one was severe autoimmune diabetes, which is akin to your type 1 diabetes or LADA. Then you had severe insulin deficient diabetes, but it was not autoimmune. So patient had insulin deficiency, but they were not autoimmune. Now, perhaps this could be because of pancreatic disease like pancreatic dysfunction. In India, this type of patients you'll see with type 3C diabetes, which is also known as pancreatic diabetes. Then you had severe insulin resistant type of diabetes. You had mild obesity related diabetes, and you had mild age related diabetes. These were the 5 clusters of diabetes that they saw in their population. Now, how were these clusters classified? So they took these clusters based on these parameters. They took the age of diagnosis. They took the BMI of the patients. They took the HbA1c of the patient at the presentation. They took the GAD antibody, the HOMA beta, which is the measurement of the beta cell function, and the HOMA IR, which is the measurement of the insulin resistance. So these are the parameters. Based on these parameters, they classified the patient into these categories, into these subclasses and these clusters. And they said that these are the different clusters. These are different types of type 2 diabetes, and perhaps or types of diabetes. So instead of saying that patient has type 1, type 2, others, we can say patient has cluster 1, cluster 2, and so on. Right. So that's the classification which they gave. And then, interestingly, Indians also. So Dr. Mohan's group from this paper by Anjana et al. Did a study called the INSPIRED study. Now, Dr. Mohan had a huge database of Indian patients, which is called Indian Diab study. And taking this database, what he did was that they analyzed the data. They did what is known as a K clustering. It's a machine learning system, very simple to use. And they found these clusters, and they actually found that unlike the Sweden people, where they had 5 clusters, they said that we will take only clusters of type 2 diabetes. So this cluster 1, which is the Scandinavian cluster of severe autoimmune diabetes, is rejected because we are only making clusters of type 2 diabetes. So by definition, a type 2 diabetes will be autoimmune negative. So then they took autoimmune negative patients and they classified it into 4 clusters. The first cluster was severe insulin deficient diabetes, which is exactly the same type of cluster they saw in the Swedish study. Then there was insulin resistant obese diabetes, which is the mild obesity related diabetes type of cluster. Similar cluster again, you can see there. They had cluster 3, which is unique. Now, this cluster was not seen in the Scandinavian countries, which is combined insulin resistant and deficient diabetes, which they call as CIRDD, which is a very unique cluster to Indian patients. And then finally, you had mild age-related diabetes, which is again similar to what they saw in the Scandinavian cluster. So some of these clusters were similar. So cluster 1, 2, and 4 were similar to what they saw in the Scandinavian countries, whereas cluster 3 was a different cluster, which was unique to Indian patients, which was not seen in the Scandinavian study. So this is the broad difference in the Indian cluster. And so from here itself, you realize that depending on the ethnicity of the patient also, type 2 diabetes tends to differ in terms of even clusters, not only just individual patients, but in terms of cluster as well, there are differences. Now, then of course, there are a lot of patients who have what is known as maturity onset diabetes of MODY. Now, MODY, the classic definition of MODY is that MODY is a patient who is having 3-generation history of diabetes. So they have a strong family history of diabetes. Now, most of these, MODY is a group of monogenic diabetes. So here, what typically happens is that you have 3-generation history of diabetes. Often, this age of presentation is very different. And often the age tends to reduce with every generation. So maybe the first generation person presented at 30, then somebody presents at 25, then next generation presents at 15 years, right? So there is a reduction of age of presentation also. And if you see, that's the typical thing. But if you see these patients, they typically don't fall into your classical type 1 patients. So they do not have severe ketoacidosis and other things at presentation. They also don't fall into your typical type 2 patients. They might not be obese patients. They might not have insulin resistance and so on. So a lot of these patients now, in fact, recognizing MODY or recognizing monogenic diabetes is the epitome of precision medicine. If you can recognize, remember, this is a genetic disorder. And if you can recognize this genetic disorder, there is some very specific treatment for different types of MODYs. So there are, in fact, 11 or 12 different types of MODYs. And each of them, some of them have different treatment. And certain MODYs, we don't require treatment at all. So how do you recognize patients with MODY? Right now, the classical definition is that, patient should not fit into type 1, should not fit into type 2. His typical BMI should be less than 25. You should have three-generation family history. At least one of them should have onset of diabetes before 30 years of age. But that's for a group, right? If let's say an individual patient, and what type of individual patient? So this is a algorithm which is suggested by one of the groups where they said, let's do this. A patient is diagnosed to have diabetes less than 30 years of age. So if you remember, original patient was 25 years, so you can say perhaps, right? Is he on insulin? Is he not on insulin? Let's say he's on insulin. So you look at the C-peptide of the patient, right? And if the C-peptide is very low, typically less than 0.2 nanomoles per millimole, urine C-peptide is something they check, right? And if the C-peptide is very low, it is likely to be type 1. If the C-peptide is still good, then you look at the GAD antibody and IA2 antibodies. If GAD antibody, IA2 antibodies are positive, again, think of type 1 or a slowly progressing form of type 1 like LADA. And if GAD antibody, IA2 are negative, then you should consider doing a genetic test for this patient. And that is what will give you the diagnosis. Secondly, if the patient is not on insulin already, that would be a good idea to check there. So that means the patient does not. So patient is probably treated like type 2 diabetes. You check the GAD antibodies. If they're negative, then you go for genetic testing. And then genetic testing turns out to be positive. You think of monogenic diabetes. If it's negative, think of other forms of diabetes. So that's the broad way of, you can take a screenshot of this. You can use this algorithm in your clinical practice also. So this is how you often could recognize patients. Now, I'll tell you a real story. In fact, we got the patient's report. So, unfortunately, I could not put that in the slide at the last moment, but we just got the report today. This one kid is an 8-year-old who presented to us in the emergency with diabetes, and we presume obviously 8-year-old presented to be type 1. He had ketosis, but not severe ketosis, not typical of what we see in type 1. Hypoglycemia was quite severe, so blood sugars were very high. So we treated this patient like a type 1 patient, but there are certain things which did not click in the mind. That something is wrong. This is not type 1. There are some unusual features. So one, he had strong family history of diabetes. There is a 3-generation history of family and a lot of these family members had diabetes at young age. Secondly, he did not develop severe ketosis. We did his GAD antibody, which was negative. We started the patient on insulin. Once his glucotoxicity reduced, we checked his C-peptide. His C-peptide was not unusually not very low. So again, all these features made us feel that perhaps we're not dealing with type 1. We are dealing with something else. So yet we treated the patient like type 1 diabetes, and that is how you should. And discharged the patient on basal bolus insulin. Patient was on a regular follow-up with basal bolus insulin. But because something did not fit right, we had a genetic test for this patient for monogenic diabetes. And just today we got the report, and turns out he has MODY4, which is PDX1 gene mutation, which is unusual because, in fact, I'll tell you, I was just looking at the literature. There are not many cases reported across, forget India, not many cases reported across the world also. There are isolated cases, isolated families of this MODY4. It's a rare genetic disorder, right? So this is something, where you keep your eyes and ears open. Perhaps if the patient is also ready to spend some finances, remember a genetic test is costly. If there sometimes you have some clinical trials going on and all that, so sometimes it may be done free of cost as well, but often commercially it is done. It costs a little bit of money, but if you make the right diagnosis, perhaps you could perhaps offer them a different treatment rather than insulin, which was what was offered to this patient, right? So why is recognizing MODY important? Because if you recognize MODY2 does not require any treatment. Sometimes these patients are misclassified as type 2 diabetes and given treatment. They don't require treatment. So MODY2 does not require treatment except during pregnancy, which is a complicated scenario. Perhaps we'll discuss that when we discuss MODY. Perhaps we can have a discussion on MODY itself, which is a very interesting topic. MODY1 and MODY3 very interestingly respond beautifully to sulfonylureas. That is the beauty of MODY1 and MODY3. And MODY5, and in fact, we have now 3 patients with MODY5 in our follow-up. One father and son with MODY5. MODY5 can have renal complications, and they can tend to develop CKD. And very interestingly, the MODY5 which we diagnosed first in the child. It turns out the father was also our patient, and we didn't know that. So the MODY5 patient actually came to us. He was first diagnosed to have the child was diagnosed to have chronic kidney disease, and then again the pediatric nephrologist sent a genetic testing and found that this is MODY, and then they checked the sugars, and he was already having diabetes. HbA1c was 7.4, with blood sugars of 130 fasting and about 200 post meal. So then they sent this patient to us, and then this patient is brought to us by his father. He said, "Father said, I'm also your patient." The father also is CKD, right? Father is in his 30s. And then look, you also could be having MODY5, right? So we did his father's genetic testing also turned out to be MODY5, right? So it's the reverse diagnosis. We made the diagnosis first in the child and then in the father. So and father was on our follow-up. So again, unusual feature, we missed it out, right? Interestingly, we treated this patient like type 2 diabetes because we didn't realize that patient had CKD. It was basically a typical archetypical type 2 poorly controlled diabetes. So we didn't realize that we missed out the fact that he had CKD at a young age, which was unusual. There are other certain unusual features also which we didn't pick it up. So I think again, sometimes by keeping your eyes and ears open, you might even type 2 diabetes may be MODY may be misclassified like a type 2. So that is something we need to understand. So this is why you should understand precision medicine. So this is why precision medicine is so important, that you are able to give the right diagnosis and hence offer the right treatment and prevent the complications. Now let's look at some current developments in the field of precision medicine. So where is precision medicine really coming at? Now precision medicine, like I said, is a big thing. You have an initiative called the PMDI initiative, which is Precision Medicine in Diabetes Initiative. You can check out. There's a website for this. This is backed by the American Diabetes Association and EASD. So both the two major organizations for diabetes are backing this system, and there are a lot of available grants also for this. So we are going to, once our application becomes and we do one of a few studies of our application, we are planning to apply for these grants as well. So PMDI is an initiative by ADA and EASD where they're looking at precision medicine at the center stage of diabetes management. Now, this is the algorithm which they've given for precision medicine. Like we discussed, we have precision therapeutics. So have a tailor therapy based on the diagnosis, precision treatment, precision prevention, and then of course look at the lifestyle measures, treatment adherence, side effects. Remember, precision medicine also looks at side effects. So if you give the right treatment to the right patient, less likely the patient will have less likely to have side effects, right? So that's the overall perception of this precision medicine. Okay, so we looked at some clusters, and let me see how we can perhaps use precision medicine practically right from today. So let's say today a patient comes to me. Can I apply precision medicine system to us? Yes, you can. So what you need to do is, remember, we practice diabetes. I'm sure most of the audience is from India. So if you're from India, you can try to apply the cluster which is given by Dr. Mohan et al. I'll show you how to do that. We have some tools available for you. You can try applying that. Uh, Test it out and give me some feedback as well. So some free tools for you to put your patient into a cluster. So you have, you remember you have these 5 clusters, which is the original Scandinavian cluster. Similar clusters are available for Indians as well. Broadly speaking, cluster 1 is the severe autoimmune efficiency diabetes, which is basically type 1 diabetes. So a patient comes to you with cluster 1, it is type 1, and you need to treat this patient with multiple daily doses of insulin, so basal bolus insulin therapy. Now your cluster 2 patient is your severe insulin deficient diabetes. This is a group of patients who have insulin deficiency as the main pathogenesis. This is again similar to cluster 1 Indian cluster, where you need to give sulfonylurea or insulin. This will be the right choice of the drug for these patients. If you have cluster 3, which is severe insulin resistant diabetes, which is again, this is a cluster which was seen in Scandinavian countries, but it was not seen in Indian patients. Indian patients, in fact, had combined insulin deficiency and insulin resistance. So our patients did not only have insulin resistance, they had insulin resistance and and insulin resistance and insulin deficiency. So they had combined thing. So if it was a Western cohort, you would probably perhaps consider giving this patient metformin, SGLT2, GLP-1RA, or pioglitazone. Indian group of patients, what I'd suggest is you can consider giving these drugs plus possibly even considering insulin or sulfonylurea because they also have insulin deficiency, right, or beta cell dysfunction. Okay, then you have cluster 4, which is mild obesity related diabetes. This is similar to IROD cluster, which is the insulin resistant obese diabetic group, where you can consider giving this patient metformin, SGLT2, or GLP-1. And then you had cluster 5, which is mild age-related diabetes, which are mild patients, age-related diabetes they have. They generally do not develop too much of complications. These patients can be easily treated with metformin or DPP-4. So you can again take a screenshot of this and save it. So if you find the right cluster, if you're able to identify your patient in the right cluster, you could perhaps offer them the right medication for treatment. So this is precision medicine 101 today, right? This is something you can practice today. You don't have to wait for the future. You don't have to wait for us to develop our app. You can start practicing this right from your clinic from tomorrow itself. So this is a paper there where they looked at these clusters, and they also saw that not only were these clusters, likely to respond to certain treatment, there are certain complications which are common in these clusters. So as you can understand, you had cluster 3, which is severe insulin resistant diabetes. These patients tended to have more of diabetic kidney disease, NASH, ASCVD, and so on. Then you had cluster 4, which was mild obesity related diabetes, which tend to have a lot of fatty liver, NAFLD. Then you had cluster 5, which is mild age-related diabetes, where the problems were basically they are frail, they had cognitive decline, dementia, and all these complications. So you need to prevent hypoglycemia in these patients. That is something important. Then you had cluster 2, which is severe insulin deficient diabetes, where you are likely to develop neuropathy, retinopathy, ketoacidosis, and so on. And then you had cluster 1, which is severe insulin autoimmune diabetes, where the complication expected is a possibility of diabetic ketoacidosis. And that is something you need to keep in mind. Now, broadly, what we learned from these clusters is something which has emerged in terms of understanding. Very interesting. Listen to this carefully. What has been found is that those people who are more insulin resistant, if insulin resistant is your predominating problem, they tend to develop more of diabetic kidney disease. Whereas those patients who tend to have insulin deficiency as a common problem, they tend to develop more of diabetic retinopathy, which is very interesting, right? So if you have more insulin resistance, you tend to develop more of kidney disease. If you have more of insulin deficiency, you tend to develop more of retinopathy. In fact, every patient with diabetes have both, but the degree of this may differ. That's why I told you, if you've not done this, on Netflix, we have another talk, which is the talk on the unifying theory for pathogenesis of diabetes. Listen to this talk. In that talk, we have clearly said that every form of diabetes has both the defects. They have insulin resistance and have insulin deficiency. In fact, diabetes does not develop without these factors. It's the degree of these deficiencies or resistance which differs in different patients. So, and that is what is typically, illustrated by this cluster. So, a severe cluster one, severe autoimmune, or cluster one and cluster two will have severe insulin deficiency. Their main problem is insulin deficiency, but they'll also have some degree of insulin resistance. Whereas something like a SIRD cluster three, where their main problem will be insulin resistance and insulin deficiency will be a minor problem. So that is how you typically can distinguish. And that's why, even though these forms of, we are trying to divide the diabetes, we are also trying to unify the pathogenesis and understand that in a unified manner. Okay. So like I said, the potential complications also differ. So cluster 1 and cluster 2 tend to have more of ketoacidosis, retinopathy. Cluster 3, which is insulin resistant diabetes, tend to have more of diabetic nephropathy, ASCVD, and so on. Again, insulin resistance strongly linked with ASCVD. Then you have cluster 4, more of NAFLD or NASH. And we have the cluster 5, which is elderly patients who tend to have more of, risk of hypoglycemia, risk of fracture, risk of dementia, and so on and so forth. Okay. So this is the present state of precision medicine. That is, what are the different clusters and how you can apply simple logic and, give treatment and prevent complication based on the cluster which you have identified. But now let's talk about the future. What does the future lie for precision medicine? So the future actually will, all these biomarkers and everything. I think we'll perhaps throw this out of the window. I am developing something for this, but this will probably, last for my lifetime. But my children's lifetime, they will probably treat diabetes in a completely different way. They'll say, just like we say, oh, zamane mein 100 years back, before insulin was discovered, how did they treat insulin? How did they treat this inhuman way in which they used to treat diabetes? Same way, my children will say that how did these old people treat patients with type 2 diabetes? Completely wrong. So why? Because what will change everything is genomics, right? So genomics based treatment is the future for type 2 diabetes treatment. Remember, this is without a doubt, right? So if you do genomics based treatment, you will understand, whether the patient has monogenic diabetes, whether the patient has a polygenic form of diabetes, which is type 2 diabetes. And within the polygenic form, what kind of genes are affected? Is it obesity related genes which are affected? Is it beta cell failure related genes which are affected? Does this patient have some form of lipodystrophy? Does this patient have a lot of hepatic issues? Right? And again, based on what kind of genetic defect you have, you will give the treatment. So if the patient has obesity related genes affected, why don't you give this patient a GLP-1, right? Patient has beta cell failure, why don't you give this patient a sulfonylurea insulin, right? So based on this and based on polygenic risk score, we'll be able to treat the patient in a very precise manner based on genomics. So this is the future, right? Not the present. We are far away from genomic based treatment, but this is where ultimately we'll be going to. Remember, it's not as easy as it seems. Apart from the monogenic disorders, the polygenic disorders like type 2 diabetes will have multiple genes involved. Hence, you'll still require, some application, some software to detangle this and give you the right treatment. So there's still, some software which will help you in this. But at the end of the day, this is where we are going to go towards in terms of drug. Now here comes what we are doing, right? So lot of talk, right? Talk is cheap, right? What really works is action, right? And that's why we talk a lot about precision medicine, but that this is now our way of showing what we are actually doing for precision medicine. And we have created a system called diabetology.co.in, which is it's in an early phase. We are still in a research phase. The software is still we have developed some bits of it, but it's not complete. But we hope that by end of this year we have a ready-made application available to you. This domain is registered. In fact, you can go to the website right now and explore it. It's called diabetology.co.in. Right? There are some free useful tools as well where you can use. Now, what is our idea? The idea is that a patient so this is only for type 2 diabetes patients. So if a patient comes to you with type 2 diabetes, you input some patient variables, right? Put in some data. I'll show you what kind of data we are collecting. Then it goes through a precision engine where you do the cluster classification, you do various other calculations. Then it gives you clinical deep insights. Then you have a personalization filter, the second layer. So Indian patients is very important, right? So economics are very important. Patients' beliefs are very important. So you put this through a personalization filter, and then it gives you a prescription. In fact, it will give you not only will it tell you what drugs to use, it will give you the prescription. So it'll give you the treatment plan with rational, and we have used AI at the back end to give you evidence also. So not only it will tell you why, tell you what to do, but it will also tell you why you should do it, right? That's the thing. And give you the suggested prescription, right? Looks very futuristic, but let me tell you, we have almost finished, I'll say 60% of the work, right? Just 40% remaining, where it's almost close to a reality of what you will be able to see. So this is our website. In fact, updated the website a little bit, so you might not look exactly the same, but this is diabetology.co.in. The video down there, you can check it out. It's basically just a demo of what you're planning to do, not what is reality right now, but what will ultimately go towards. We have a free module for cluster classification. In fact, now we have uploaded a multiple module kind of thing. You can check that out. You have diabetic kidney disease management module. You have we have those who follow me have that we have made an app called Centurion Insulin app, which tells you whether your patient with type 2 diabetes needs insulin or not. We have another system called Endo AI. I'll discuss this a little bit. It says coming soon here because it's an old screenshot, but it's actually already come. So it's something for you to use, and you can there's an email address below. If you find this interesting, if you find something you can relate to, you can check it out and you can send me an email. Okay. So we recently uploaded one of the things which you already finished. That's called multiple modules. In fact, instead of using the cluster classification module, you can directly use this multiple module thing. Here you enter the patient's data, right? So this QR code you can use to access this. It's a complicated, whole link is a little complicated. So you can either go to diabetology.co.in and click on multiple modules, or use this QR code. You enter the patient data. So in this case, if you remember original patient was 25-year-old male patient. So we enter 25 male. Does this patient have osmotic symptom? Yes. Is the patient a smoker? No. So we're taking some cardiovascular history also. Does the patient have history of ASCVD, history of early ASCVD in family, so on and so forth? So all this data we are collecting. Then clinical examination parameters, blood pressure, weight, the height. It will calculate the BMI for you, the waist circumference, and so on. Right. Very important. Then the lab parameters: fasting blood sugar, post meal blood sugar, HbA1c, C-peptide in fasting, C-peptide post meal. Now this is actually we have included this because if you see original paper by Dr. Mohan or Anjana et al., they had included C-peptide in their cluster classification, but they also said that you can do the cluster classification without the C-peptide. So right now the software accepts C-peptide and does the clustering based on C-peptide, but we are going to develop a new module, modify this, where C-peptide will become will not be mandatory. It will be optional. So if you enter it, great. Otherwise, you may not. You may skip it. Right. So even if you skip it, it will give you the cluster. Right. You can use the creatinine. You enter the urine albumin creat ratio of the patient, and here it will give you the answer. So what cluster does the patient fit into? Does the patient need insulin? Right. The patient may need insulin. Diabetic kidney disease category also tell you whether the patient is a candidate for Pindidon therapy and so on. There's one more which it got cut off. It will also tell you the cardiovascular risk of the patient. It will also tell you whether the patient requires statin and what dose of statin you should prescribe to the patient. So it will tell you all these details, and that is something you can really look at. So try this out, check it out. In fact, don't take my word for it. Check it out. Try some random hypothetical patient data and see how it really works. And if you find an error, if you find something which is doesn't fit, send me an email. Right, I'll be happy to. We are, in fact, like I said, we're actively developing this. So this is something, if you give me a feedback, it's something which is going to be very useful to us. So again, we are happy to say that we recently got funding. Very recently, you can see 15th of May, we got this funding from RSSDI. It's not a great amount of money, but the point is that it really endorses our view. And we have Dr. Arvind Gupta, who is a legend in this field from Jaipur, who is actually mentoring us on this project as well. So we recently had a very nice discussion with him as well, and we are looking towards doing the clinical validation study of this as soon as the software is updated. So we are again happy to share that we have now some backing from the premium research organization for diabetes in India, RSSDI. So why is this project unique? Now it's currently the only known announced project for precision medicine in Indian patients, right? All the other precision medicine projects are outside India, right? This is all self-funded, self-propagated concept, which is, I think, nobody is doing this right now, right? Not only will you give you will include not only just the treatment aspect, but also give you complication prevention, not just therapeutics. We also, idea is to generate good evidence base. So we're not going to do it just because, we can. We are going to generate good evidence also for it. We'll see how much applicable it is in real life scenario. We'll do personalized medicine, right? Not only precision medicine, but personalized medicine. So we'll also do health economics, social cultural factors. Remember, Indians are unique in that sense. So we'll use all that. And of course, the idea is so far, none of the, personalized medicine or precision medicine tools use AI. We are forefront of AI, and we are using AI and machine learning to improve the algorithms. So overall, I think it's a unique concept, which is perhaps I'm promising you the moon, but I am confident that we can be able to deliver something which is amazing and unique. Uh, we would love to have your collaboration. Right now, you're looking for about 5 or 6 centers. We are to carry out the RSSTI back study. We already have a few centers who have agreed to this. But if you're interested something, and if you're having, if you're working in the field of diabetes, if you are part of an institution, academic institution, or even a corporate hospital, trust hospital, have your own clinic, whatever it is, it doesn't matter. Scan this QR code. There's a Google form. Fill this Google form and try. Uh, what we'll do is somewhere down the line we'll try to, maybe not the current study, the future study, but we'll try to involve you as a part of the precision medicine journey. We're trying to develop this, in a very different way. Not something you've seen other tech developers do it. Remember, at the end of the day, I'm still a doctor. That's my first priority. Patient priority comes first, right? So if even that small, whatever precision medicine algorithm we give you makes a difference to your patient today, that's something, which is ultimately the aim, which is looking at. So we're looking at collaboration, right? We're looking to seek your help. So try putting your data here, and try filling this form, and then we'll get back to you. I promise you, not be tomorrow, maybe not day after tomorrow, but we'll try to get in touch with you as early as possible. So that's the whole idea of the diabetology.co.in. Now, like I said, uh, we are at the forefront of AI. We already developed this Endo AI. It's available at endoai.co.in, right? Check this out. Trust me, it is amazing, right? Not that it's something which I developed. That's why I'm telling you this. It's something which is amazing. Endo AI is basically what Endo AI is. That it's a large language model for endocrinology. There are different, you can go to our YouTube channel, Endocrinology India. You can search that on YouTube, and you can see a video which are made of what Endo AI is. Endo AI is already, we already have, last I checked yesterday, we had about 450 users, and users have asked more than 700 questions on this Endo AI platform. It is like something like a chat GPT, but uh, for doctors by endocrinologists, this is something which is very unique. In fact, you can put case scenarios, you can put MCQs, and give you an answer. Not only give you the answer, give you the correct answer, give you a very beautiful answer. Right? It's something which is quite amazing. So try this out, check it out. It is, like I said, still in a beta phase, so there might be perhaps some errors, some maybe the system may be a little slow, but show your love instead of criticizing it, because this is a lot of hard work behind this, a lot of thoughts behind it, right? Give it a little time. I'm sure it may not live up to Google or Microsoft, but we'll probably never get there, but we'll still be something different and unique, and boutique in our own way. So that's basically Endo AI, right? So that's the talk. Some take home messages. What is basically precision medicine? Remember, precision medicine is here to stay. Whether we like it or not, it's going to be around. The current era is focused on the currently everybody's looking at subclassifying and reclassifying the types of diabetes. So that is what really things are working towards. The future is, of course, focused on genomics. So ultimately, whatever I develop will be taken over by genomics, just like, the entire computer world is taken over by AI right now. Genomics is going to take over all our practice. We'll just like, we do, ELISA changed, endocrine practice, I would say, or radio immunoassay change endocrine practice. Same way, I think genomics will change endocrine practice for good. And our project, which is called diabetology.co.in, is backed by RSSTI, and we are forefront on the development in this field at present in India. So I thank you for a patient listening. Would be happy to take some questions, right? And like I said, would really love to collaborate. So if there's something which you feel you have the email on the website, you can check it out. You can send me an email, right? Don't expect an instant reply, but I'll as soon as I check it, I get time, I check it, I try to reply to every mail that I get. So thank you.
Thank you so much, sir. It was impressive, as Dr. Manshuk Shah is saying. It was amazing and inspiring work that you just talked about. Definitely, precision medicine is here to stay, and AI is definitely coming in. It's real. So unless and until we update ourselves, it's going to take over a lot of things. Yeah. So thank you for this presentation today. I'll request everyone to put up their questions if you have any. This is very new area that sir has discussed today, so you must have absorbed a lot of things. So if there is any query, just let us know. I'll take that up. So till then, Dr. Bhupendra Singh has asked how to categorize patient to different clusters.
Yeah. So how do you do that? You do that using right now we have just one model which was given by Anjana et al. By Dr. Mohan. Uh, like I said, you can go to diabetology.co.in, click on multiple modules, put in the data, and it will give you what cluster your patient falls into. So for classifying the patient into different clusters, you'll need the following data. You'll need the HbA1c of the patient. You'll need the BMI of the patient. You'll if you don't have BMI, you can have the weight and height, and you can enter it in the computer, and it will give you the BMI. Our system will give you the BMI. You will require the fasting C peptide. You will require the post meal or stimulated C peptide. You require this right now, but like I said, the original paper also said that this is not mandatory. So we'll also try to kind of you know uh, go away with it. But right now you'll require it. You'll require the triglyceride. You'll require the HDL. So these are the parameters you'll need. If you enter these parameters, it will tell you what cluster your patient falls into. Right. So like I said, the various clusters, the Indian cluster. So which Indian cluster your patient falls into. So that is what you'll do. So that is how you classify the patient. So these are the data which you require to classify your patient into the various categories.
Right. Thank you, sir. Thank you so much. I can see loads of amazing comments that are coming up. So, Dr. Bhumik is asking, can you suggest some literature to read all this, some references?
Yeah. So there are two major references which I would suggest. One you must read is the ADA guideline, or it's not a guideline, it's a consensus statement perhaps. They wrote one in 2019 and they revised that in 2022. The 2022 one includes one of the authors is Dr. V. Mohan. So you can check that out. You can search for these papers; they are available freely online. You can check this out, and these are, I think, perhaps the most valuable literature on precision medicine because this comes from ADA, right? You can also go to Endo AI, and on Endo AI, you check the guidelines AI section. In guidelines AI section, we included the earlier guideline, 2019 guideline for precision medicine. We have included that in that, so you can select that and ask questions. If it's there in the data, it will give you the answer. So that is how you can search more for it. So these are two papers. Besides that, there are a lot of other papers written, and I think a lot of these papers from India are written by Dr. V. Mohan. So there's this one paper in JAPI where he talked about precision medicine in detail, and there's I think another paper by Dr. Mohan which also includes Dr. Kalra and Dr. A.K. Das and other things. So you can check out this paper. I think I don't remember the journal, but there are two papers by Dr. V. Mohan on this topic, which are all both very good and very recent. So they are 2022 ish papers. So you can read those. These are the definitive guides for precision medicine. But I think the primary one you should consider reading is the ADA one, right, which you should read.
Thank you, sir. Thank you so much. Speaking of Dr. V. Mohan, so sir had taken one lecture and we invited him for Makers of Modern Medicine, where he talked a lot about precision medicine as well. So if you're interested, you can go back to the session where he has explained his work in detail. So that is also available on Netflix. So I'll take up another question. How Dr. Nisha is asking, how common is medullary nephrocalcinosis in uncontrolled type 1 diabetes in children?
Uh, well, I don't know if there's any data for that, right? I mean, it can happen. It's not medullary nephrocalcinosis. Perhaps may not be directly linked with maybe a well-controlled type 1 probably would not have metabolic nephrocalcinosis. So I think, how common? Well, I don't have the data for that. But I mean, it's not something which is very common. So yeah, but then they do develop diabetic kidney disease, which is your typical diabetic kidney disease rather than other forms of kidney disease. So that's something.
Understood. Thank you, sir. So another question is cure actually possible, or is it just control with precision medicine? So
Uh, well, I think cure and control where the lines are really blurred, right? At the end of the day, what exactly is cure? There's nothing like cure, right? To be honest, type 2 diabetes, there's no cure, right? It's only remission. It's, and if that remission is not maintained, it comes back, right? So there is always a recurrence also. So, uh, the point is that, there is, well, no cure for anything per se. So end of the day, it's still control of the disease. Any disease you take, right? Whether it is, in fact, in endocrine, most of the diseases are well controlled, quote unquote, right? So cure is something which is, it's not an infection where you can give an antibiotic and cure. It's not going to happen. It's a disease state. It's a state of being, right? And that state, uh, you know, you might be in that state or you may not be in the state, right? But if you're not in that, you might go there and vice versa. So there is, in a more philosophical sense, I'd say there is no cure for that. Neither would precision medicine give you a cure. End of the day, it's just the management, which is control. Yeah. So I think one thing I'll tell you, and which you're trying to include that as well, is I'm not sure in the recent update we have put that in the multiple modules, but it'll give you whether your patient is a candidate for diabetes remission. So if you have a type 2 patient, it'll, you put in the data, there are some algorithms for that. So you try to include that. We perhaps it may not be finished right now in this version, but it will tell you whether your patient is a candidate for diabetes remission based on the direct trial data. That is what will eventually include that as well. But at the same time, that doesn't mean that the patient or doctors will not have to make the effort. It's no pill which will cure the thing. It's still an effort which everybody has to make.
right, understood. Thank you, sir. Thank you so much. Dr. Sunil is asking, what is diabetes reversal? So which cluster of patients is valid for diabetes reversal?
Yeah, so that's what I was just talking about. There is no term like reversal. There is nothing like diabetes reversal. It's just remission. There is a difference between remission and reversal. I think remission means that, like I said, it will come back. If you do not maintain that state again, it will come back. So, like I said, we are having one in the multiple modules thing. We have already a separate module we made for which patients are candidate for diabetes remission. We'll include that in the main module, multiple modules thing. So there will be patients who tell you whether your patient, the data you entered for the patient is a candidate for diabetes remission or not. Amongst the clusters, which clusters the diabetes remission is possible? If you take Dr. Mohan's cluster, there are two clusters where diabetes remission is a possibility. One is cluster 2, which is insulin resistance obese diabetic. In fact, that is the only cluster where there is a meaningful reason for why you should attempt a remission at all. The other category where remission is probably possible is the cluster 4, which is the mild age-related diabetes. So in these two clusters, remission is possible. Perhaps mild age-related diabetes, you'll not, it would not make much sense to attempt that. But the only cluster where you should really try this is the cluster 2, which is insulin-resistant obese diabetic. And that's the cluster where your chances of patient going into remission is a possibility, is a distinct possibility. The other clusters, cluster 1 and cluster 3, both have insulin deficiency. And because they both have insulin deficiency, it's unlikely that the patient will, even if the patient is able to, have remission, perhaps the maintenance of remission may be very difficult. So these are things. So I think Dr. Mohan's cluster 2 is the one where remission is possible.
Understood. Thank you, sir. Thank you so much. We have covered almost all the questions, and it is very new area for all the doctors. And thank you so much for your time today.
Thank you.
Yeah, would love to have discussion on some amazing topics like you just mentioned. There's a lot of technology that is coming in medicine, and we all need to know that. So we can definitely plan discussions around it. Thank you so
Absolutely.
much for today. And it was amazing discussion.
Thank you.